My talk is going to be a sort of curtain raiser to the issue that we're going to be discussing about. Basically, I'm going to talk about an introduction and approach to patients with cataract and corneal astigmatism. Just mention the different modalities which are available right now. I have no financial disclosures. So to begin with, the question comes, why correct astigmatism? Literature says that about 20 to 30% of the patients who have cataract surgery have a corneal astigmatism of about 1.25 diopters or more, while almost 10% of the patients have about 2 diopters of astigmatism or more. Moreover, when we talk about premium IOLs like multifocals, etc., again, it's mentioned in literature that for a multifocal IOL, an astigmatism of more than 1 diopter can lead to significant reduction in visual quality. So yes, we have to correct astigmatism. This is just a flow chart which shows the different modalities which are available for correcting astigmatism with cataract surgery. We can basically divide the astigmatism into pre-existing astigmatism or some residual astigmatism which is left even after doing the best during the surgery. So for the pre-existing astigmatism, we have 2 main methods. One is correcting by incisions, corneal incisions, limbal incisions, and so on. Second is correction with intraocular lenses. For the residual astigmatism after cataract surgery, we can either go to surface ablative procedures or piggyback IOLs depending upon the logistics at that time. I'm going to address all of these issues one by one. To begin with, correction with incisions. When we talk about correcting astigmatism with incisions, basically there are 4 categories that we are addressing. First is a simple phacoemulsification done on the steeper axis of the cornea. Second is something known as the opposite clear corneal incision or the OCCI. Third is what we call LRIs or limbal relaxing incisions. And fourth one is an astigmatic keratotomy or corneal relaxing incision, whatever terminology you would like to use. Starting with emulsification on the steep axis of the cornea, basically it can be used to correct up to 1 diopter of astigmatism satisfactorily. Now throughout my talk, when I say correct, I don't mean 1 diopter is going to become 0 diopter. If we read literature, it says that if we leave about 0.25 to 0.5 diopter of with the rule astigmatism in our patients, it helps them in depth perception. So a patient who comes with a astigmatism of about 0.5 is a patient where you probably wouldn't want to correct anything. But if the patient has about 1 diopter of astigmatism, the easiest and the most common way to reduce it to some extent is having the phacoemulsification incision on the steeper axis. Also in this, making an incision in the superior axis leads to more reduction than the temporal axis, the reasons of which will be discussed later. Again, for this, the proper marking of axis is very important. There's no point in having an incision 20 or 30 degrees off the steep axis. And of course, the ergonomics have to be taken into account. A superior, an inferior temporal or inferior nasal incision might not be so convenient for the surgeon. So this is a topography of a patient which had about 0.9 diopter of astigmatism at almost 90 degrees. And you made a superior incision here. Post-operatively, the patient was left with 0.5 diopter of astigmatism, as I had said. Again, opposite side clear corneal or OCCIs, these can be used to correct up to 1.5 to 2 diopters of astigmatism. Here, an additional corneal incision is made in the opposite end of the steep axis. There is no manipulation in the entry, they just make the entry and leave it. This is a small video which shows OCCI. This is right at the beginning of the surgery. This is the steeper axis. You make main incision at the superior end. And then we go ahead to the opposite end of the axis and make another. That is it. We do it and we leave it. This was a case of OCCI which had about 1.2 diopter of astigmatism pre-op and was left with again about 0.5 diopter of astigmatism. Then we come to the limbal relaxing incisions. These are done at the limbus, generally about 450 to 600 microns thick. They are typically paired. Theoretically, there are a lot of nomograms available, and theoretically they claim to correct up to 4 diopters of astigmatism. However, that doesn't really happen that often. This is a small video, a little old video, sorry for the visual quality. So the incision has been made on the steeper axis, and this is the end of the surgery. The surgeon is just marking the arc, it's about 30 degrees, and we are making incisions right at the limbus. In the main incision, we are going in continuation with the outer lip of the corneal wound. We're not going through and through. Again, an LRI patient of 1.4 diopters was reduced to about 0.5 diopters after surgery. Now we come to what people call astigmatic keratotomies or corneal relaxing incisions. They are done a little closer to the center than the LRIs, somewhere between the 5 to 9 millimeter zone. These are more precise, and now we can get them done with femtosecond lasers. So femtosecond laser increases the precision as well as the depth of the incision dramatically, and with it, you can modulate the amount of astigmatism being corrected more closely. So these are two small videos. So as you can see, the AK is made from the femto machine. This opening up, now one advantage I would like to point out, if you make an astigmatic keratotomy with the femto laser, you always have an option whether to open it up on table or you want to wait and see how the cornea reacts and open it up later on the slit lamp. The two videos that I have here, we opened it up during the surgery. This step is at the end of the surgery. You can see the wounds have been hydrated, and all you have to do is basically just take a Sinskey hook and go and open the incision up. That's your orchid keratotomy. Here, the surgeon opens it up during or just before IA. All of us hear a lot that all these relaxing incisions and cuts should be made at the end of the surgery or at the beginning of the surgery. Basically, you want the eye to be taut for cut to be made. But with an femto-assisted astigmatic keratotomy, the cut has already been made. All you have to do is open it up. So it doesn't matter which stage of the surgery you do it. So just rounding up the incision part, the story so far, the advantage of correcting astigmatism with incisions is that they are technically easy, don't require additional expertise, they are very cost effective, and theoretically they can treat up to 3.5 to 4 diopters. However, practically, I guess 2 to 2.5 diopters is maximum that you can get predictably. They do have disadvantages. Mainly, the predictability is not 100%, and regression still remains to be a big issue with incision methods. Now coming to the meatier part of the talk, correction with the intraocular lenses. Again, we have two options: intraocular lenses, toric intraocular lenses, or piggyback IOLs. Piggyback IOLs is generally used for residual astigmatism. Now, toric intraocular lenses, very quickly, I'm just going to go through some headings. They are more precise and predictable. Again, no extra steps required in the surgery. Just with your phaco, you need to insert a toric IOL. They can correct very high amounts of astigmatism, almost 12 to 13 diopters in our experience. And they are independent of post-operative healing, which the incisional methods are not. Why I say almost is there is still some healing with the main wound, etc. Anyways, so we have a whole plethora of toric IOLs available in the country. However, I'm an ex-consultant of Narayana, and I have the faculty of Narayana. So at Narayana, our main experience is with these three. One would think that we are a little Western inclined and a little foreign material inclined, which is not so. We also believe in Make in India. We have used off and on the Ultima Smart Toric. The reason for this is that this toric can be customized to very high astigmatic powers. We recently treated a patient with 13 diopters of astigmatism. We'll be coming to that later. So the entire story of a toric IOL depends on the ability of it to correct the astigmatism, which again depends on how stable the lens sits in the bag. It's all good to have a good surgery, put the lens in, but if the lens rotates, then you've had it. Literature says that a 3-degree rotation will remove the astigmatic correction by 10%. A 10-degree would reduce it by 30%, and a 30-degree rotation of axis nullifies the entire astigmatic correction. So rotational stability is very important. Now, how do we do it? There are two main aspects of a toric lens. One is the biomaterial it is made of, and second is the IOL design. When we talk about the biomaterials, the main things they're talking about is basically how adhesive or how sticky the material is to the lens capsule. A very big term is in vogue, which is called bioadhesivity. Now, it's a very catchy term. As soon as you say adhesivity, the first thing comes to mind is Fevikwik, chukki mein chipkai. You put the lens and it gets stuck and it's not moving. In reality, it is not so. There are different materials, acrylic, PMMA, silicone. hydrophilic acrylic, hydrophobic acrylic, and literature suggests that hydrophobic acrylic lenses have the maximum bioadhesivity. When I say maximum, I don't mean that you put it in sticks, and I have a video later on to show, but it has maximum bioadhesivity among the other materials. When we talk about the IOL design, there are basically two designs which are available, the plate haptic and the C-loop, where it has been proved in literature that both are equal when it comes to rotational stability. This is again the features. Most of the lenses, as you see, are either hydrophobic or hydrophobic lined. We use plate and haptic both. The correcting power is, if you combine all the lenses, we can correct up to from -10 to up to +32 of sphere, and cylinder up to 12 diopters can be corrected with these lenses. Now, this is a small video where I would like to bring out the point of bioadhesivity. This is right at the end of the surgery. This is a hydrophobic acrylic lenses. This is taken on a rescan. And if you can just pay attention to just below the lens here, this is the posterior capsule. At the end of the surgery, we hydrate the wounds. And you can see how the capsule is bouncing up and down. Ideally, once you inject the lens, the capsule should have been somewhere here, but it isn't. So what we do, we decide to go and tap it. Of course, the capsule comes up. Okay, should stay there now. You hydrate, and goes again. Let's try a third time. We again go, tap it, comes up, but you can't leave your wound unsealed. And this is what happens. Now imagine you had a toric IOL, and you had this amount of space between the posterior surface of your lens and the PC. I don't know what kind of sleep you would get. I wouldn't get much. Anyways, the second important aspect of toric IOLs, which we'll be covering in details later again, is patient selection and decision making. There are a few bullet points that I want you to keep in mind when we talk about that. Monofocals. We have monofocals to correct up to 0.75 diopter of astigmatism as well. But in practice, about 1.25 and above is taken as a regular cutoff for using toric IOLs. For multifocals, the cutoff should be 1 diopter. Regular bow tie astigmatism is most suitable, not meaning that irregular astigmatism is not suitable. Moderate amount of irregular astigmatism with regular central cornea, you can use a toric with reasonably good results. Patients which have any dystrophies or which are liable to go in for keratoplasties later should be avoided, because of course the astigmatism is going to change later, and any complicated cataracts should be avoided as well. Now this is a typical topograph of regular bow tie astigmatism. The patient is going to do fantastically with the toric IOL. This, however, is something where we should definitely avoid toric IOL. This is a very, very irregular cornea. Quickly, I'm going to run through a few things which we'll be discussing later again. Preoperative evaluation, always better to do with the topographer. The different kinds of topographers, the pros and cons will be discussed later. Preoperative marking, axis marking, very important. You can do a perfect surgery, but if the lens is off axis, like I said, everything will be lost. So very important to do it in upright position on the slit lamp. Why? Because when the patient lies down, cyclotorsion occurs. Cyclotorsion has been reported to be anywhere from 4 degrees to 15 degrees in certain individuals. So if a cyclotorsion occurs in one patient who has 15 degrees, you've lost half your toric correction there only. Ways of marking is with the slit lamp, beam tilted at the axis of the lens. We have bubble markers available now. And people who are rich and can afford the iPhone 6, you have a lot of apps for that as well. Surgical procedure, basically 2 things to be kept in mind. Please try to save the bag. Do a rexis which overlaps the lens equally. Wash off all the visco. And in case you do have a complication, you can abort toric IOL. Post-operatively, again, axis marking can be done by a slit lamp. We can use topography. And we can use aberrometry. All of this will be discussed in details later. Quickly, residual astigmatism is the astigmatism which is not corrected in the first procedure. If you have access to photoablative infrastructure, LASIK and PRK are the best options. In case you don't have access, you can't afford, or you've given incisions in the first surgery, piggyback IOLs are a very good option. Rayner has got nice something called a Sulcoflex, which can correct up to 3 diopters of residual astigmatism. Now, in the end, fatafat, key takeaways. Monofocals can be used up to 1.25 diopters. Sorry. Patients who cannot afford toric or non-availability, up to 1.25 diopters, you can correct with incisional methods. In case of non-toric non-availability, you can actually go up to 3 to 3.5. When I say 3 to 3.5, I don't say that you will be able to correct it with incisions. What you will be able to do is reduce it to a more acceptable level with incisions, maybe a 0.8, a 0.9, even a 1 diopter. So a patient who has 3 diopters pre-op gets 1 diopter post-op will still be happy. If torics are available above 1.5, you should aim for toric. And very high astigmatism can be tackled with piggyback IOLs in the first setting itself. Multifocals, again, more than 1 diopter, you should try for toric. And under that, you can use incisional methods. These are my references. Thank you so much.